Spinal Truth Show weekly podcast edition. I'm your host, Dr. Caleb Slater, here with Chris, an expert on POTS. Chris, tell us about POTS.
Well, you smoke it, you put it in a thing, you eat it, all kinds of stuff.
And clearly your expertise is shining through. What it basically boils down to, it's a cluster of symptoms that a lot of people out there have. And primarily it's a dysautonomia where they have trouble regulating heart rate, blood pressure, and they'll end up lightheaded, dizzy, or they'll end up with a syncope episode, which is passing out.
What is the other word you said?
Dysautonomia. It's dysregulation.
Gotcha.
So your regulatory system, right? Like your heart rate, your breath, that's just self-regulated, or that's auto-regulated in your body.
And this will be just something that comes on, or is it?
Yeah, so there are a whole bunch of, it's typically brought on after a trigger. It could be an infection, they're listing COVID,
Okay.
Could be a pregnancy, could be a trauma, could be anxiety, could be coupled with other common conditions like Ehlers-Danlos syndrome. But at the end of the day, the cause is pretty much the same cause that you're gonna get with a lot of these type of symptoms. Idiopathic, meaning medical term for I don't know why.
We don't know.
I don't know.
So it's similar to your fibromyalgias and...
Yeah, and it actually, so it's funny you say that because another condition that kind of mimics a lot of this is PPPD.
Okay.
Persistent postural perceptual dizziness. And I think
rolls
that,
off the tongue there.
Right? So what does that mean to you?
Say the words
Persistent,
again. Okay.
postural perceptual dizziness.
Something in your posture causing dizziness
Yeah.
persistently.
Yeah. So I think that's the fibromyalgia of dizziness, meaning they don't know what is causing it, and it is truly idiopathic. It's the same stuff: anxiety, trigger, trauma, something could cause it, but they don't know why.
I feel like the outlier through those is trauma, right?
Well, and when they say trauma, you got a concussion, you
Okay.
got a fall. It could be psychological trauma because they do put that in there, but I think they're generally speaking more physical trauma.
Okay. Having worked with you now for a while, all this says thoracic spine to me.
Which is great. And you know what? So many people out there are listening to this right now and they're maybe about to tune it out, okay?
No.
Don't do that.
We're going to talk about POTS soon.
But what we're going to do is we're going to prove it because on
Okay.
next week's episode, we're going to interview somebody who came in specifically for POTS, diagnosis of POTS, 2 years of POTS, wasn't getting the right treatment, was getting all the normal treatment for POTS, wasn't getting any better, saw us, came in, 3 visits, 80% better.
So, what you're telling me is that the normal treatment was ineffective. But what is the normal treatment?
Such a good question.
Thank you.
It is multifactorial.
Okay.
So it's medication typically to manage heart rate and blood pressure. It's dizziness training. So a lot of dizziness training, they'll do balance training, they'll do fall training. So they train you when you do feel like you're about to pass out, how to fall so you don't hurt yourself.
Okay.
And the dizziness training, I'm losing the term right now, but they basically provoke your symptoms and they let it calm down. Provoke your symptoms and let it calm down.
Just so you get used to it?
So you get, yeah. So, and I'm missing the term right now.
Okay.
I know the term, but it's...
Doesn't sound like you know the term.
Yeah, so it's basically, God damn it, it's getting you used to your symptoms. There's a term for it.
Daniel's going to look it up for us.
Yeah, I don't like the fact that you called me out. Now I'm all rattled.
Welcome to my life. No, I know. It's it sounds like a term you shouldn't learn because it sounds ridiculous when you say it, in theory.
Yeah, it does, and it should sound ridiculous,
Yeah.
right? Like, the fact that they say, you have your symptoms, we can't really fix them, but what we can do is we can get you used to them.
Yeah. It sounds like the kitchen sink kind of approach.
And it is, and that's a lot of approaches out there. Again, you'll hear multifaceted, multifactorial, right? You'll hear multidisciplinary. All that means is that we don't really know what's really going on, so we're going to do a little bit of everything, and across multiple disciplines, across multiple treatment modalities, meaning like medication, physical, even psychological. Right, so they'll treat the anxiety that's underneath it, or the anxiety that's provoked from these conditions.
I was gonna say, this seems like something that would cause a lot of anxiety.
And that's the treatment process out there.
If you'd like an appointment, go to thespinaltruth.com and schedule today. We offer both in-person and telehealth appointments, and unlike the medical system, we look to the root of your problem. We look to find the cause, the why your problem, your symptoms are there in the first place, and we expect quick improvement. We expect improvement in pain, range of motion, or strength in the first visit, and 50% or more improvement in most conditions within 4 to 5 sessions. So if you're tired of being in pain, if you're tired of the medical system and its approach failing you and you want something different, go to thespinaltruth.com and schedule today. Now let's get back to the show.
Well, let me ask you this. Passing out can be scary, and I assume there could be very, very serious health things that could be triggered passing out.
Sure.
So do they rule out more serious things first?
Yeah, and you know what? So I shit on the medical profession a lot.
You do?
No, right? But that is actually what they do well. And
okay.
So they rule out, we use the term like nefarious, right?
Yeah,
so
yeah.
This is like a brain tumor, a structural heart abnormality, right? Something like that, right? They rule that out, and they rule that out well. We're pretty good at that in general. But when they don't find anything, what is kind of egregious is that we come up with a term for the symptoms that somebody has after we haven't found anything. And here's your POTS, here's your PPPD, here's your fibromyalgia, right? So all of these terms, they're basically applied to after you weren't able to find anything. But the problem is that now that we have this term, now this person thinks this is my problem, this is my diagnosis, and it's not a good diagnosis. It's just basically a label that we slapped on.
Yeah, and I think it's easy to say that now, but think of the patient and their health journey. One day they're doing something, all of a sudden maybe they pass out.
Yeah.
They go to the ER, they go through all these serious tests and rule things out, and then...
And if you keep telling them, I don't know, they're going to get really frustrated, and they're not going to have any faith in you.
No faith. And so when you give it a label, at least they can say...
I know,
something.
and I get it, I understand it.
Yeah.
But it's wrong.
It's wrong.
Yeah.
Because it doesn't lead to appropriate treatment.
No, and it's very well said. It leads to treatment, but treatment that is based off of symptom management and control than actual treatment. So I don't term it treatment. And that's where, if you wanted to label all this stuff symptom management, I'm cool with that.
Yeah.
But that's not how we label it as a medical world. We label it as treatment.
Yeah, that makes sense. So... POTS.
Have the word you're looking for. Habituation.
Habituation. And you couldn't get that? We're talking about pot.
I actually know. I was just letting you.
Right?
Just seeing if you could. You're the PT. I'm just saying.
Habituation.
Habituation. So now, if I'm training to become an astronaut, habituation sounds like
a good idea.
Sounds like a good idea.
You get used to those G forces, right?
But okay, so you're diagnosed with POTS. How limiting is that? Can you drive?
So positional orthostatic tachycardia syndrome, positional.
Okay.
It's typically with change in position, typically with getting up from laying down. It could be activity induced, it could be sitting down too quickly, it could be rolling over too quickly. Again, typically it is getting up from sitting down.
I've had experienced that before, maybe not the same symptoms, where you get up and like you feel a little lightheaded for a second.
Yeah, so it's lightheaded and or dizziness.
Okay.
It also has chronic fatigue. You have your brain fog-like symptoms. You have poor tolerance towards working out.
Interesting. Okay. Are you stiff? Are you like?
There's typically these patients have some pain, some stiffness. They typically have some trouble like getting up in the morning or falling asleep, or they wake up at night. Their heart rate randomly jumps, and it can be just when they're sitting, or it can be when they're like doing a light activity, like you're just at the gym doing like a simple bicep curl, let's say, and your heart rate is acting like you're sprinting.
Interesting.
Here is the cool part. Oh, and a lot of these people have anxiety.
Of course.
Every single one of those symptoms is explained by your T2 to T6 area of your spine.
So the thoracic spine.
So the thoracic spine, the upper thoracic spine, and guess where the patient that we're going to interview next week, guess where she was the most tender when I was pushing on her spine.
I will go with the thoracic spine for 500.
Yeah, and it's specifically the T2 to T6 area of her spine.
Is there, and maybe this data isn't even available, but is there a correlation to activities that people, jobs or something that?
So it's another good question. I think it's becoming more and more prevalent. So like, if you took away the label, POTS,
Yeah.
and now you just went with chronic fatigue, you went with brain fog,
Yeah.
you went with headaches and dizziness, lightheadedness, activity intolerance, increased heart rate.
Yeah.
That sounds like a lot of other people out there right now. That I bet you a lot of people out there would say I have 3 or 4 of those.
I call that being alive in 2025.
Yeah. So why is that more and more common? And it's the boring answer. It's because, by the way, that T2 to T6 area, what happens to that area when we sit?
Yeah, we bend over.
It is basically the anchor of your head and neck. And you're bending over and you're using that area as your last, like, holding on to that string, right, to support your head and neck.
If you're just listening, would you refer to that as like your neck hump area?
It is pretty much your neck hump area.
Okay, so that's easier to visualize. So yeah, all that weight from your head, this is the anchor for it, essentially, right?
Right.
And how often are people looking down at their phone, looking down at the computer, bent over all the time?
And think about it too. It wasn't until, I like to think about this a lot because it helps me put things into perspective. 2007 is when the iPhone came out.
Yeah.
Right? So that was 18 years ago. 18 years ago, our world changed. And I know there was computers before that, but like they weren't as user friendly, right? And they weren't as ubiquitous, and they weren't in your hand.
They weren't with you at all times.
Yeah.
Yeah.
Now all of a sudden, because like the only thing, the people were on their BlackBerry, but not everybody had a BlackBerry. I'd say like that was it was more in like the business
maybe if you
world.
worked at like the stock exchange.
Right, exactly. Or you were a CEO or something like that, right? Like you had a BlackBerry, but most people, their phone, I still had a Nextel phone, I think, for a long time.
You didn't have
It
one of
was a
those razors?
walkie-talkie.
You got to get one of them razors.
I never had a razor.
Well, you weren't a cool kid, I guess.
Right?
I actually never had
I had that
either.
LG Slide though,
Yeah.
and I think that was my favorite phone.
All right.
Like you could flip it up and there was a keyboard on it.
Yeah.
Anyway, so our world changed, and that change of our world changed what we do throughout the day.
Sure.
I mean, literally now everything is at the tip of our fingers. I mean, you can order food, you can do your work from home, you can you can do your entertainment from your hand. When you used to be out at a restaurant or at a doctor's office or whatever, you were looking around, maybe reading. Now, if you're not looking at your phone, right? That's odd. If you're going to the bathroom and you're not looking at your phone, that's odd.
Yeah, I pull a book out and I get looks.
Right?
Like,
what is this guy doing? Where did you get that from?
What is
You mean an online book?
No. I can't read it. I can't do the Kindle. I can't. I like the real deal.
So again, like, why are these symptoms, these cluster of symptoms, more and more prevalent? And by the way, another thing that you can throw into those symptoms is some GI gut issues.
Okay.
And again, this area of your spine has some innervations to your intestines, to your GI, and through a few different areas, like the upper cervical area, which isn't the one we're talking about, but through the vagus nerve has some innervations. So you throw in that cluster, and now that starts to sound like a lot of people out there.
If you're out there and you're in pain, if you're tired of the current medical system failing you over and over and over again, just giving you answers that numb you, pacify you to your symptoms, and are largely based on medication, injections, and surgery, and you want a different way, maybe even a better way, look for my book, The Spinal Truth, A New World of Medicine. In it, each chapter I talk about a different symptom, different condition, different body part, and how I view it a little bit differently than the current medical system, and how my treatment has helped so many people out there when they've been let down with the typical approach. This is the way I think medicine should be. This is the change in healthcare I think we deserve. So thespinaltruth.com, you can look for my book on Amazon, Kindle, Apple, and on audio.
So do these symptoms come on individually over time, or do they all appear kind of at once? Or
it's a good question. Like? I think there's normally like a crescendo event.
Gotcha.
I think they were, in general, there were some of these symptoms here and there sporadically, not like maybe fairly mild, and then there was an event, an infection, a fall, a headache, a concussion, something that now elevated everything that was already there to the forefront of your attention, and now it's there.
And when you are diagnosed with POTS and you get these symptoms, do they wax and wane in their...
Yeah.
Okay, so they're not always consistent.
They're not always consistent.
Which, isn't that telling in some ways?
It's very telling.
Okay.
And if you've read my book, if you've listened to me say anything...
I try not to. No, I'm just kidding.
Variability of symptoms. Sometimes it's there, sometimes it's not.
Yeah.
Sometimes you can do this activity, sometimes you can't. Sometimes it's on one side, sometimes it's on another. Sometimes it's this intense. Other times that variability presentation, that tends to mean spine.
So if you are experiencing these variability in presentation, you go to your doctor, that means the treatment you'll get will be very specific to that very specific symptom you're feeling at the moment.
At the moment, or remember, this is a cluster of symptoms, one more predominant, if we're talking specifically for POTS. But it's a cluster of symptoms, so whatever is your, like let's say 4 out of the 6 of them for you, and I have 4 out of 6, but 2 of them don't overlap with yours.
Okay.
Right? So we have the same problem, but with a different presentation. And I actually think this is very explained through the spine as well, okay? Because we're making it simple and we're saying T2 to T6. This has innervations to the heart. This has control over the autonomic nervous system, right? But let's say for me, my big problem is T2 to T4.
Okay.
Your big problem is T2 to T6.
Gotcha.
You're going to have similar but different symptoms, similar but different problem than I have, but we have the same problem. And that explains why a lot of these people out here have very similar, somewhat overlapping problems, but they also present differently.
Yeah. So what kind of medications would you receive?
Again, blood pressure and heart rate.
Blood pressure and heart rate, just to keep it regulated in some way?
Yes.
Okay. If you stop taking the blood pressure stuff, but you treat your thoracic spine, will your heart rate and everything, in theory, come back down to normal level?
Yeah, and you shouldn't do both at the same time. So a big
Gotcha.
thing I say with my patients is minimize variables.
Yeah.
We want to know beyond a shadow of a doubt, or as much as we can, that what we're doing is having the effect of what's going on with you. Meaning, are you getting better, are you getting worse, is nothing happening?
Yeah.
And we want to know that is because of what we're doing. If you stop taking medication and you start doing this treatment, if you're better, if you're worse, if your heart rate's up, if it's down, if your blood pressure's up, if it's down, we don't know why.
Gotcha.
So you don't want to change, you only want to change one thing at a time. And also too, with medication, you have to be careful, you have to taper off.
Right.
The patient that I'm talking about is actually, I think her goal is to get off the medication. So I think she's planning on tapering off of it relatively soon. She was kind of chomping at the bit to start, and I wanted her to do this program for a little bit longer before she started. And she had already talked with her doctor about she's taking it PRN as needed, so
Gotcha.
she's allowed to taper off.
So I know the answer to this question, but I'm going to ask it out there if they're a new listener, a new watcher of this content. Say I'm experiencing these symptoms. Should I have an MRI done of my thoracic spine?
That's another very good question. The answer is no.
What?
And you know what? And that's a fair response, because a lot
Yeah.
of people out there are going to say, well, you're telling me it's T2 to T6. Why not have an MRI and see what's wrong?
Yeah.
I've said this so many times, it's hard to. An MRI is more misleading and inaccurate than most people realize. And there's a whole bunch of reasons why. Number one, degenerative changes occur over time, meaning by the time you're 40, you are about 60 to 80% likely to have degenerative changes. Those degenerative changes are herniated discs, spinal stenosis, facet arthritis, spondylolisthesis, spinal stenosis, foraminal stenosis, central stenosis, ligamentum flavum hypertrophy.
Not the flavum.
Your flavum is thick, my friend.
It's so hypertrophied.
And the point is that you have these changes, but without having symptoms.
Yeah.
So when you get an image, when you get an MRI, and they find whatever they find on that image, that MRI, they're going to miscorrelate to your symptoms. So I would much rather go off of your history, your symptoms, the presentation, their behavior, your movement, and then your response to treatment. For me, that's so much more accurate and specific to you than this 2D picture. I know they say 3D, but it's still a 2D picture that's being read in a position of comfort, meaning you are laying down for the most part, right? So it's already an inaccurate depiction of you yourself, because you're not sitting, you're not changing positions, you're not twisting, you're not looking, you're not stressing or lifting weights. You are lying down in a position of comfort, okay?
Yeah.
So it's already not a complete picture of you. And what the problem is that everybody out there would ask that same question that you just asked, because everybody out there thinks the MRI is the gold standard. MRI, CT, imaging, something is the gold standard of figuring out what's wrong with your spine. And the other problem is that it kind of is.
Well, yeah, it will get you a diagnosis.
It will, but it'll lead you down the wrong path.
But you got to think of it. These doctors are going to be chomping at the bit to ascribe something to these symptoms.
Yeah.
Right. If it's an amalgamation of all different kinds of things.
Yeah.
So don't get the MRI.
Don't get the MRI.
But what do you do?
Well, all right, and let me put a little bit of a qualifier on that. You do need to rule out nefarious things.
Sure.
So you might need imaging to rule out a space-occupying lesion like a tumor on your spine, right? Sure. So get whatever imaging, brain imaging, EKG, cardiac imaging, MRI, get blood tests, get whatever. Just be careful specifically about the imaging to your spine. Be careful about getting a diagnosis based off of those results. All you want from all of that is ruling out an underlying cardiac defect, a tumor, an infection, something, right? Once that's ruled out, now the next thing you do is you treat your spine.
So we treat our spine. So what does that look like?
So for this specific patient, and I'm going to come out with a book for this, a book in a video series. I gave her 4 exercises over the course of 3 treatments. After 2 treatments, she was 70-80% better. I just gave her another exercise on her last session. So I gave her 4 exercises total, all aimed at that thoracic spine, all aimed to get it. The simple answer is, if we think that this, looking down at your phone, reading, computer work, driving, sleeping, laying on 2 or 3 pillows, if we think that is the cause, the answer is to undo it.
Yep.
So all you have to do is move that area of your spine in the complete opposite direction, contract the muscles of that area in that range to fatigue with resistance, and there you go.
Sounds like I'm going to need a foam roller.
Foam roller is step 1.
Step 1.
Yeah, step 1, it's very helpful to get your neck out of that position, your upper back.
Yeah, so, it's unfortunate that the majority of the patients you see are the people who have gone through this full spectrum of treatment, starting with probably the EKGs and the MRIs and all that stuff, and then finally getting diagnosed with POTS, and then going through treatment there where they're endlessly going to PTs and chiropractors and all that kind of stuff while taking medication and still not getting relief. And then they come to you and you show them a few exercises and it's like that.
Yeah, it's a double-edged sword. I'm very proud of that.
Yeah.
But I'm very sorrowful for the medical profession.
And
the people that are they're suffering with this for a while and they're not getting treatment. And not to downplay it, but this was 4 movements, right? And I'll ask the patients this. I'm like, did we do anything like groundbreaking, earth-shattering? Am I using any like fancy equipment? Like I have the least amount of equipment in my facility than I ever have in my career, because I used to use all the fancy stuff, the lasers and ultrasounds and TENS units and neuromuscular stim, and I know I said laser, but there's a different laser for like postural training and balance training stuff, and I used to use all that stuff, and it just wasn't as effective than what I'm doing now, which is just being very specific at the area of the spine that I'm trying to move. The thing is, so people always ask like, what's the treatment? And I do want to show it, and we do show a lot of it on our channel and stuff like that, right? But it's also the education with it, what to expect, what not to expect,
right.
What means good, keep going, what means bad, stop. That is priceless. You need that.
Right, and everybody's different. You don't just, if you were just throwing the kitchen sink at someone and treating everyone the same, that would be one thing, but everybody gets an evaluation specifically targeted towards what they're dealing with.
Well, and kind of like what we were saying, right? Like we've simplified it to this like T2 to T6 area, but what if this patient also has an underlying like osteoporosis?
Right, exactly.
What if this patient has had these symptoms for a year and they're mild, and this other patient had these symptoms for 6 years and they're severely intense?
Yeah.
You're going to get a little bit of a different, like, do this much of it, do it this aggressive from one to another.
Yeah.
Even like positionally speaking too, right? Like with this patient I'm talking about, for the first visit, I was pretty aware of her getting on and off the floor, right? She had some dizziness that provoked the first visit. That's very normal. I told her that. I talked her through it. I talked to her about how to get off the floor slowly, so that way, you know, she's managing those expectations. I told her that the dizziness should dissipate over time, and I gave her a pretty clear timeline for it.
Yeah.
All of that stuff's very helpful to not only keep you safe, but also to set expectations.
It's motivating too in some way.
I mean, not for me. I have to say the same thing over and over again. It's kind of, I should just record it at a certain point.
You should make a video series.
Put them in. We're making a video series. Apparently, they're a lot slower.
You should write a book about it.
We're writing a book. Apparently, it takes longer than I thought.
Yeah.
And it's hard to do it right too, because of what we're talking about. Is everybody is a little bit different. So you either have to be all encompassing,
Yeah.
which you could almost be synonymous with boring and long, or you have to be bare bones, basic, which is incomplete and surface level.
Yeah.
So you have to kind of pick one.
It's a balance.
I'm trying to ride the middle line between the two. Yeah.
POTS, huh?
Yeah. POTS.
I guess I learned something today.
You think we answered all the questions on POTS?
I mean,
Who's most likely?
Women are most likely to get it between the ages of 15 and 50. One of them is because of their chest.
okay.
It
Makes
puts
sense.
more pressure on that area.
There's weight there. Yeah.
There's weight there, right? There's counterweight, you
Yeah.
know. Another one is pregnancy. When you get pregnant, so I'm going to teach you some things now.
I've never gotten pregnant.
Hopefully you've had this talk.
Okay.
But when you get pregnant, you get a mechanical obstruction in your abdomen. You can't bend forward,
I have one of those.
right? Because you can't bend forward through your lumbar spine, you have to compensate with your thoracic spine if you want to move, right?
Yeah.
Once you do have that child, now you are somewhere around a year of holding and breastfeeding, and somewhere around 3-ish years of holding.
Yeah.
Right? And that's only for one child. So, and when you're holding, when you're breastfeeding, you're looking down and you're
Yeah.
rounding your shoulders. So
Bending down for the baby.
bending down to
yeah.
pick up the baby, but the dad should be doing that too. So we're trying to.
I was
you
a
know.
stay-at-home dad. I know.
Hey, my first child, I changed, I would say 40% of the diapers. What do you think?
Sure.
I like that response.
But I didn't do the feeding, and to be fair, I offered, but to my wife's logical point, she was like, I would have to get up in the middle of the night, pump, in order for you to feed. So like it makes no sense.
Sure. So it does sound like child care, child rearing, child bearing, all that stuff raises the average
Yeah.
a lot, and it makes sense why.
You want to know another reason that you wouldn't think of?
I was thinking hair or clothing.
You nailed it. Hair, ponytails.
Gotcha.
I never would have thought about this until I worked with a PT and we were doing like a headache talk. And during the headache talk, she was talking about how she gets a headache in her car when she has a ponytail because her head's
Oh my goodness.
Yeah.
her head's so much forward.
Yeah.
Never would have thought about that in my, like, why would I think about that, right?
Yeah.
But it makes sense. Like, if you're lying down with a ponytail, you're either kind of to your side a little bit or your head's jutted forward. If you're sitting up with a headrest, your head's jutting forward. And I mean, this is accumulation over time. This isn't like you wear a ponytail and you get POTS, right?
No.
This is you wear a ponytail, once a week for 15 years.
Which is exactly why it's so hard to probably diagnose. Because it's over time.
Because it's over time.
Yeah,
Yeah.
it's
If it
not-
was just an incident,
Yeah.
it's obviously more. If you fall down the stairs, you break your wrist.
You're like,
Well, so you fell down the
fell down the
stairs. Yeah.
I've heard that car thing from many different women. They don't ever seem to change anything with car seats to fix that problem.
I remember car seats for a little while had a little hole, and I never knew why, except I thought maybe they wanted less material, right? But maybe that was a ponytail hole.
Yeah, I mean, it makes sense.
Yeah.
POTS, PPPD, is there any other similar ones in that vein?
For children, AMPS.
Okay. Similar presentation?
Yeah, more pain dominant, but
Okay.
pain and fatigue. FND.
Okay.
It's another one of so it's a neurological disorder that they can't figure out why. Literally, they did all their tests, they couldn't find any structural issues, so now they're saying FND.
And you have treated anyone with that?
Mm-hmm. Yeah, it's
With
the
success?
same thing.
Same thing.
FND is kind of like your new your new fibromyalgia.
Gotcha.
That-
Fibromyalgia so last year.
Well, but you know what? Like for a while, it was very, we'll say, in vogue, right? Like everybody was getting fibromyalgia, but then they realized that there is no underlying diagnosis. We can't attribute it to anything. It's a whole cluster of symptoms, and because of that, it started getting a lot of I don't know. This isn't a great term, but like scholastic heat, right?
Yeah.
Like a lot of people saying like, well, is this even a real thing? And blah, blah. And then, what became like the new fibromyalgia, and it's probably still the most common, like, and I'm using fibromyalgia as a global term given to patients with a variety of symptoms and conditions that they were being told that this is the problem when we can't figure out the problem. That's what I'm using fibromyalgia as. What do you think is the new fibromyalgia?
Oh, I have no idea.
Oh, you do. You got the hair thing. I was actually really, really impressed with the hair thing. You can get this.
I don't want to say anything that would sound dumb. I don't know.
All right, most people going to your doctor with an unknown cluster of dizziness, headaches, fatigue, brain fog, what are they going to get diagnosed with in 2025?
Not anxiety, but
Anxiety.
Oh, really?
Yeah,
Okay.
anxiety. They're using a lot of anxiety medications to treat your chronic pain these days. There's a whole, I forget the guy's name, but I really disagree with it. There's a whole guy out there that created this whole system of it's your brain's misperception of the pain that's causing it. So it's your brain's problem that's causing your physical pain. Who is it? I want to say Sarman, that's not it. I can picture the guy.
It's just like your brain is like
Is he a
ran.
podcaster for longevity or
No,
a person?
he's a PT person.
I mean, the anxiety umbrella definitely exists.
So now if you have pain and they can't figure out why, they're going to say you have anxiety. If you have chronic fatigue and they can't figure out why. And please, I am not saying that people don't have anxiety. But that's exactly the sentiment, right? Who doesn't have anxiety these days, right? Everybody's diagnosed with anxiety because you can put that to pain, you can put that to fatigue, you can put that to dizziness, you can put that to
that's
malaise and brain fog, and you could put that to any of these, and you could say, well, anxiety can be a causing factor. My point is that I think if we added this spine-centric approach in the evaluative process, we could catch a lot of these that are being mislabeled. And with anxiety, it's psychosomatic. Mm-hmm. Right? It's your mental state causing this. So you say how psychosomatic wasn't an acceptable term. Don't quote me on this, but I think it was somewhere in like the 70s or 80s. It was after a war that it became more prominent. And I'm bad with my timelines. I'm bad with my wars.
like Vietnam or something.
I don't
or
know.
Gulf War was in the 90s.
I'm bad with my wars, Chris.
Okay,
I don't know.
All right.
But it wasn't recognized, and it was largely refuted in the psychiatric world.
Interesting.
And this was not that long ago. At the latest was the 50s, but I think it was closer to the 70s, early 80s.
Now it's fully embraced, right?
Now it'd be weird if you didn't know the term psychosomatic. Most people didn't know that term, and we're talking 50 years ago, right?
Yeah.
Most people didn't know that term. So the evolution of conditions and how we label them and symptoms, it's actually very interesting. But if you look at it, it's also very telling because it tells you really how much we don't know, how much we don't get, and how much we just keep kind of like recycling the same amount of symptoms and clusters of symptoms into different terminologies as we go.
Get a freaking foam roller.
Get yourself a foam roller. Start there. You know what? Our thoracic outlet series that we have on TikTok
Has some great.
that takes you through 3 out of like the 4 or 5 that I would do for this area.
Yeah.
Yeah.
Yeah, I mean, if you're out there and you're listening, we do have many videos featuring that foam roller exercise.
Yeah, and it's not the only thing that you should do.
No.
And you do need to keep up with it for like 2-ish weeks. And you do need to couple it with strengthening in that range, and you do need to be taught how to progress both the foam roller and the strengthening in that range. So like that's the process, right? But I expect when I treat patients, I expect somewhere around, let's just say for these specific symptoms, right? What we've outlined, I expect somewhere around 50% or more improvement within 5 weeks.
Yeah.
So maybe that is a good place to end, because if you're out there and you're getting treatment for this and you're not seeing those results, approximately, right? Like let's say you're 5 weeks in and you're 20% better, and you keep seeing positive improvements over time, great, you know?
Yeah.
But you should be seeing something.
Next week is an actual patient who had all these symptoms, who had this diagnosis over years, who got these treatments. You're going to hear her journey, her story. You're going to hear what she went through with me and what the results are.